Hey guys, welcome back to Care with Candace. So it's coming up about week 6 of being a trauma surgical ICU nurse. So I figured I'd give you guys a little bit of an update of the things that I've learned, the types of patients that I've seen, and just kind of talk to you about things to expect when you are going to trauma. All I have to say is if you want some drama, go to trauma, okay? I titled this video Brain and Hands because literally when it comes down to trauma, anything that's on the inside of your body can end up on the outside of your body in a matter of 2 seconds because of the reason why you came in. We'll have patients from motor vehicle crashes. We'll have patients from out of state that'll get life flighted to us because we're the closest trauma center to them. We'll have patients with broken pelvises from motorcycle accidents. We'll have patients who have gunshot wounds to multiple parts of their body, stab wounds, anything that you can think of that has caused like any traumatic damage to the body. We will get those types of patients. And of course, like every unit probably right now going on in the hospitals, you will always get those patients that don't even belong on your unit. So it's good to have that little bit of a mix so you can kind of get some of your critical care experience as well as your trauma experience, depending on the patient load that you'll have. So far about being on my new unit, it's been phenomenal. The staff members have been phenomenal. The patients have been really good as well. Whether they can talk or not, they're still good. Every second, every minute that I am there, I have to learn something new, and everyone there is willing to teach in any moment. Okay, so they love to have new nurses come into the unit and stuff because it gives us a continuous ability to learn something new. You have a rapid, the rapid team is going to come and educate you on different aspects of your patient to kind of get you into the mindset that the patient is the absolute priority. And anywhere that you go in the hospital and any test that you take them to, your focus is the patient. Those people that are in like CT or X-ray and stuff, when you take the patient down to get those scans done, they're not watching their patient. They're doing their specific job in terms of, doing the actual scan itself. But you as a nurse have to pay attention to the patient at all times. You make the call for the best outcome for your patient. If you notice that their saturations are decreasing or the heart rate is going down, let those people know who are running those tests to stop. You need to pull that patient out in order to get them back to a adequate vital stance in order to continue that scan, or that scan is completely done and we're going back up to the room so that we can finish up what we need to do to get that patient stable. Okay, so just know that with trauma, it's a completely different ball game. When we do get floated over to our CMU, our intermediate care and stuff like that, or other ICUs, the culture is very different. When I came on, I specifically asked the team members, what is the culture of your unit? A lot of people were saying we have a great team of individuals who are willing to help at any moment, and it has never been a moment where no one has helped at all. They're always willing to lend a helping hand. Trauma is a different type of ICU to where it's even more critical, and those patients can come in with traumatic things, be hemodynamically unstable, and you have to work diligently and closely with each other in order to make sure that that patient remains stable at all times. And of course, if they do not, all right, cool, let's adjust to it and make sure that we get them back situated. So in terms of the different types of patients that I've seen and stuff, in regards to gunshot wounds, these can be self-inflicted gunshot wounds or people who have, shot somebody else. So we'll get a mixture of both of those. When I say really appreciate every single organ of your body, I am so serious. You honestly, we take our bodies for granted and don't even realize how important each and every piece of it is. And when you see patients that are in very vulnerable states to where their insides are coming out, you can't help but to, one, feel bad for what's going on, sympathize, empathize with the patient and the family members, and just try to make sure that that patient stays stable at all times. Reviewing those orders for the head trauma patients, if they have bleeds, making sure that you do those neuro checks consistently. Like when there's damage to, your brain or the different facial bones in your body, like that will correlate with different orders, and you need to make sure that you understand, say you have your optic nerve that was affected from a gunshot wound, what are you expecting that patient to look like? The pupils are not going to be looking the same. They're not going to be reacting the same at all. They're going to be different sizes. So understanding more about anatomy and physiology when it comes to this specific specialty is really important. Kind of thinking deeper in terms of how different traumatic episodes can affect the body is a big skill set that is going to develop with time. In trauma, there is this thing called a triad of death, where there's hypothermia, acidosis, and coagulopathy. So when you see a patient that has literally the triad of death coming in and they have not had their surgery yet, you anticipate all of those things and making sure that we're actively working to make sure that that patient does not become unstable, because all of those things in the triad of death can literally lead to death if they are not fixed within an adequate time. Okay, so normally you and I, normal people, we can adjust to the body adjust to the environmental temperature, and our bodies can automatically do that as well. And our trauma people, they cannot automatically adjust their body temperatures. So they'll be hypothermic, 50 or 95 degrees. Honestly, I've seen them as low as like 85 degrees. They'll come in. Some patients will be down for so long that their extremities start to become mottled, where they turn colors like gray and purple, where there's no perfusion. Why? Because all of that blood is rushing to their center core to provide more blood flow to their heart, lungs, to those vital organs. It's kind of an eye-opening experience knowing that everybody has their own life that they live. Everybody has unfortunate things that happen to them. We have to always remember that these people are a son, a daughter, a brother, a sister, a friend to someone, a godparent to someone. And unfortunately, because of some personal things that might have happened in our life, or at the wrong place at the wrong time, has caused them to be in a state of vulnerability. And now it's our opportunity to make sure that they come out and be able to function at their highest optimum level as possible. So there's been patients that have been there for quite some time, longer than I've even been there, and finally they're starting to improve or finally get some sort of placement to where they can go and transition to a different facility. There have been also different patients where their families are in denial of what have happened to them. And when you get in those situations where you as the patient don't have a living will, you don't have an advance directive, the next of kin is the one who assumes the position in order to make sure that, that their loved one is taken care of, and any decisions that need to be had, whether it's surgery or code status, are being decided on by your next of kin. So what I am going to be making sure that I do for myself personally, and I would suggest for everyone out there that's watching, please make sure that you have some sort of living will, or just get an advance directive done on yourself, like in advance. It doesn't matter what age you are, because any time that you step outside of your living quarters, something can happen to you. Don't be that one that's in the hospital and doesn't have any person to represent you, or there's a conflict within your family because Susan wants to represent you, but Bob doesn't want or wants to also represent you. Like, make sure that that's clearly stated so that when events like this does happen, the care providers know. And there's no confusion on it, and they can directly speak with that individual to make sure that all of your wishes are being held. Another type of patient population that we have at our hospital are donor patients. That's something that is definitely new in terms of like the hospital that I'm at and everything. And when it comes down to donor patients, that's something that is specifically talked about with the donor representatives to the families themselves. So like us as nurses, we never speak to the families about donating, organs or anything like that. There's a specific team that does that. And when a patient becomes a donor patient, there are certain procedures that have to be done, certain tests that need to be cleared before the patient can go down and actually have their organs removed to be transplanted to someone else. That could be in the hospital, that could be in another state. So like all these different teams, like flight teams and stuff, have to be in order to get those organs to the next person that they have as a recipient. So just knowing that like any trauma case that comes in where they don't have like any identifiable family members, or they're a trauma case, they don't have anybody to reference, those people are at risk of losing their lives. So we have to make sure that we let the organ donation individuals know that, so that they can come by and do their part. At no point is anyone coerced into becoming an organ donor. Everything is up to the person who's deciding, or everything is basically for good measures, so we're not just shipping people off and things like that in order to take their organs. That's not what's happening. It's always with a discussion with the family members, and they will be able to make those decisions unless that person already has it deemed that they are an organ donor. So when it comes to trauma, like, it's never a dull moment. Even the days that it is pretty chill and you don't have actual trauma patients and it's just critical care patients, you get to kind of pop around to other nurses and their patients and see like what they have going on as well. The different types of devices that they have. They'll have the Aspen collar for neck stabilization and C-spine precautions. They'll have pelvic wraps. I don't know the specific name for it, but pelvic wraps when they have a broken pelvis. A lot of times I will see those in like a motorcyclist who have literally broken their pelvis in half. A lot of patients come in and thinking that they're just very grateful and blessed to be able to open their eyes and know that what they just experienced was extremely traumatic, and they don't want to go through it again. They just want to be able to get out of the hospital and be able to walk. So our job is to just basically stabilize them for surgery or recover them after surgery, and make sure that they get to rehab and everything as their time progresses, as their bones begin to heal, as their surgery starts to heal them even more, in order for those patients to walk out in one piece. Okay, so like I said, when you start to see organs from the inside seeping out to the outside, that patient needs some extra love. So be very gentle, be very calm with it. Watch your reactions at all times, because the family members don't even know what it is that they're seeing or realize, and it can be very frightening as well. So keep the dignity of the patient at all times, and anything that is private to them, to their personal body, cover it up And always remember to always have a helping hand with moving your patient, because these patients, you move their neck one wrong way and that can potentially paralyze them. You know, don't give them an antibiotic when they have a brain injury or a facial injury and they can develop meningitis. Like, you have to make sure that all orders are given, all orders are accurate, verify it with the doctors, the nurse practitioners, anybody who is on the case, because one missed thing can actually be very detrimental to the patient. So stay tuned for more content about trauma ICU and anything else involving nursing as well. See ya.